First of all, thanks for everyone. It's a pleasure to be here with all of you. Today it's going to be our international webinar. We are going to talk in English because of some of the speakers. And just to start with the presentation, this is going to be for those that are not used to, this is a webinar that is performed every week, and we try to cover all the aspects on laparoscopic and robotic urological surgery. So for those of you that want some more details about how to join us in these meetings, please go to the chat box, and that will try to give you all the information you need. And today I have some very good friends of mine, new ones and some old ones. And my name is Oscar Fujita. I'm from São Paulo, Brazil. I am in charge of the urological department at Hospital Universitário da Universidade de São Paulo, USP. I am the director of the fellowship program in minimally invasive surgery at Hospital das Clínicas da Faculdade de Medicina de Botucatu, Universidade Estadual Paulista, Unesp, and I'm a visiting professor at Hospital das Clínicas da Universidade Estadual de Campinas, Unicamp. They are all three different academic hospitals here in São Paulo. And the first one that is invited for today is Benjamin Lee. Benjamin Lee is a very good friend from the United States. I met him at Johns Hopkins when I had my fellowship, and he was the chief resident at that time. And we could say that he was going to be a great urologist in minimally invasive surgery. He was a rising star at that time. And I remember him in New Orleans when we had the World Congress of Urology there. And he was at that time at Tulane University with Raju Thomas, and Ben was a fantastic urologist and a very good friend. He's at the University of Arizona, and he's going to talk about pyeloplasty. Otávio Castilho, I met about 25 years ago at Hospital das Clínicas de São Paulo, when at that time I was the chief resident. And I remember that Professor Samarap, that was the head of the department at that time, and how impressed he was about the skills of Otávio. So thanks for being with us today, Otávio. And he is from Chile at Clínica Universitária de Concepción. He's going to talk about ureteral replacement. Roberto Almeida is from Quito, Ecuador. He is one of the young minimally invasive surgeons in Latin America. He has trained with one of our good friends here, Marcos Tobias Machado, at Faculdade de Medicina do ABC. He had his fellowship there. And we all here in Brazil, and those from Latin America that knows Marcos Tobias know how good he trained his fellows. So we all know that Roberto is going to have a brilliant future. And thanks for being with us also, Roberto. Thank you so much. And the other two guys that are here today are Rodrigo Quintela from Faculdade de Ciências Médicas de Minas Gerais, and Marco Aurélio Rodrigues from Universidade Estadual de Londrina. I know these two guys for 25 years, and they are in charge of training and fellowships and medical students for these 25 years at least. And for you to be at this spot for so much time means how good you are. So thank you, Rodrigo. Thank you, Marco Aurelio, for being here with us. Rodrigo is going to talk about ureteral reimplantation, and Marco Aurelio is going to talk about body flap and psoas hitch. Before we start the presentations themselves, I want to talk about two guys that are responsible for these meetings, that are Dr. Gilvan Neiva Fonseca and Mirandolino Mariano. About 15 to 20 years ago, they started a meeting that had live surgeries, had animal lab surgeries, they had hands-on courses, and they put together about 50 different urological surgeons in minimally invasive and basic in laparoscopy. And we stayed there for like a week as proctors, and for a couple of years, hundreds and hundreds of urologists from all over the world were trained there. So Gilvan Fonseca and Mirandolino Mariano are very are responsible for the training of hundreds of guys. So these 50 proctors stayed in touch for all these years, and some of them, like myself, Marcos Tobias Machado, that is in charge of putting all the scientific program every week. And now with the help of Ricardo Nishimoto, they are doing a great job. So thank you, Tobias, and thank you, Ricardo, for all the help to put this together, this meeting today. Thank you so much. Well, we have this presentation. So Ben Lee is talking about pyeloplasty, lab and robotic. He has a bunch of papers on this area on minimally invasive surgery, and he's a star in urology and robotics. So it is going to be a great experience having his presentation here. He's here during this meeting. Otávio is going to talk about ureteral replacement. It's a very challenging situation. Sometimes you don't have much ureter to work with, so we have to be used to some techniques. Roberto Almeida is going to talk about this about retroperitoneal fibrosis and ureterolysis. So there are some tips and tricks. Sometimes you have to use momentum to wrap the ureter. So there are some aspects that has to be addressed, and Roberto is going to talk about these. Rodrigo Quintela is going to talk about ureteral reimplantation, and there are some technical aspects that are very important for you, not to have another stenosis of the ureter. And now we have more and more cases of this because of the stones and the surgeries that we are doing. And finally, and the last but not the least, Marco Aurelio is going to talk about body flap and psoas hitch for those cases that we don't have enough tissue to bridge the gap between the bladder and the ureter. So they are all very experts in this area. I hope you guys enjoyed this meeting. Please feel free to make some questions. This is the format of this meeting. Every speaker will have 20 minutes for their presentation. After each presentation, we have 5 minutes of Q&A. So all the questions you have, use the chat box to make the questions. We will try to present all the questions you have. I'm not sure that we have time to everyone, but as much as we'll make the best we can. This meeting is going to be recorded, and the microphone of the attendees will be turned off just to for us not to have too much noise during the presentations, okay? So the first presenter will be Dr. Benjamin Lee from University of Arizona. Please, Ben, if you can share your presentation. Thank you so much.
Oscar, thank you so much for that kind invitation. It It's hard to believe that it's been now, over 20 years since our days at Johns Hopkins. It's with fond memories that I remember our time there together. I bring you greetings from the United States, from the University of Arizona, College of Medicine in Tucson. I hope that someday I can give this talk in person to the beautiful country of Brazil. Would love to visit Sao Paulo and see friends from so long ago. So the title of my talk, as you mentioned, is Robotic Pyeloplasty, a Step-by-Step Approach. And really, in this day and age of COVID-19, it has been really a change, not only in how we see patients, the role of telemedicine in our clinics, how Zoom meetings have now become a weekly event. And during the freshman year in college, they used to joke about the freshman 15. And I think that this is our version of the COVID-19, where we probably need to go on a diet after some months of quarantine. So what I'd like to talk about, first of all, is first the treatment options for UPJ obstruction, discuss a step-by-step technique of robotic pyeloplasty, discuss the contemporary outcomes, and then work that we've been doing in the last 5 years on buccal mucosal free graft for lengthy ureteral strictures of the proximal ureter, those strictures that are longer than 2 centimeters in length. So as everyone in this webinar well knows, there's a variety of treatment options for the treatment of UPJ obstruction, ranging from AccuSize, endopylotomy, both ureteroscopic and percutaneous approaches, and pyeloplasty, whether it's laparoscopic, robotic, or open. And when one looks at the technical difficulty of AccuSize, certainly is probably the most straightforward procedure, with the insertion of the balloon in a retrograde fashion and the cutting element and the posterior lateral approach. And laparoscopic and robotic are certainly technically more difficult. I think certainly with the steep learning curve of intracorporeal laparoscopic suturing, the technical difficulty is more difficult early on. With the robotic approach, the facilitation of the anastomosis and the reconstructive ability of the several arms of freedom. And now that the Da Vinci Xi is available, the ability to dock and the minimization of external collisions makes the technical difficulty much less. However, the risk of hemorrhage is certainly higher with the endopylotomy approach, given the fact that the crossing vessel can't really be addressed when one is an endoluminal approach, whereas robotic and laparoscopic and open can visualize the anatomy, identify the crossing vessel, preserve that blood flow, and transpose it in an Anderson-Hines dismembered pyeloplasty fashion. In terms of morbidity, certainly the flank approach with open pyeloplasty has the highest morbidity, and the endoscopic approach the least. However, the length of stay is concomitantly higher with open pyeloplasty because of the several hospital stay for recovery. Robotic and laparoscopic pyeloplasty at our institution are generally done as a 23-hour stay, just overnight, whereas AccuSize, ureteroscopy, and percutaneous endopylotomy are generally done as an outpatient procedure. However, the success rates, certainly the highest, I think, with the laparoscopic, robotic, and open approach, over 95%. And the issue of the stent and placement of the stent is highest with AccuSize and ureteroscopy. Now, when is robotic pyeloplasty indicated instead of endopylotomy? Well, the literature really supports the evidence that in the setting of severe hydronephrosis, a poorly functioning kidney, previously failed endopylotomy, is still possible to do robotic pyeloplasty, but it's important to talk to our patients about managing expectations and that desmoplastic reaction that encases the ureter after a previous procedure. And the salvage pyeloplasty has a success rates on the order of 85 to 83 to 89%, but still certainly possible for its approach. In the setting of crossing vessel and strictures, when one has these components together, the success rates of endopilotomy decrease down to the order of about 65, 70%, whereas with robotic pyeloplasty certainly maintains high outcomes of 95% or better. Contraindications for any robotic or laparoscopic procedure, certainly active urinary tract infection because of the risk of pyelonephritis or sepsis. One needs to be conscious and have a high index of suspicion that if a UPJ occurs in an elderly patient, that this collecting system defect that on imaging, if it's not consistent with stone, one may consider doing ureteroscopy first in order to rule out neoplasm. And certainly if one has a poorly functioning kidney, if it's less than 20% function, that patient may be better served with nephrectomy if it's less than 20% and symptomatic. So my preference at the beginning of the case is to perform a retrograde pyelogram in order to rule out distal ureteral stricture. I will typically place a 6 by 28 centimeter stent, even in the average height patient, in order to allow enough manipulation of the stent so that it doesn't pull out of the bladder. The next step is isolation of the ureter. 20 years ago, one used to identify the ureter by finding the psoas muscle first and then tracing the gonadal and identifying the ureter. Now, in the last decade, we essentially elevate the lower pole and punch right in under the lower pole, come right down onto the ureter. One can isolate the landmarks of the psoas quite easily and then dissect the ureter up to the renal pelvis. It's important that when one follows that dissection in a cephalad manner, that one isolates completely the renal sinus and mobilizes that renal pelvis all the way to the sinus, because one can have adhesions of tissue surrounding the renal pelvis that can decrease in peristalsis. One can see the crossing vessel here, placement of a hitch stitch, which is essentially a Keith needle on a absorbable suture, helps to elevate that renal pelvis and align the presentation so that it facilitates the reconstructive aspect of the anastomosis later. Next step is then to spatulate the ureter, and I will spatulate the ureter on the posterior lateral aspect prior to complete transection and dismembering of the ureter from the renal pelvis. Having the stabilization allows one to avoid jaw tooth or zigzag pattern, and allows a good spatulation for a good 2 centimeters of the ureter. One can then transpose the ureter anterior to the crossing vessel. Next, often in the setting of moderate to severe hydronephrosis, I will excise some of that redundant renal pelvis and trim it. And while it doesn't necessarily help with drainage or funneling of the UPJ obstruction, it certainly helps our radiologic colleagues that on postoperative imaging shows a reduction in that renal pelvis size that helps them recognize that the obstruction is relieved. Now, in terms of the ureteral anastomosis, there are many options to perform this anastomosis. My preference is a forovicral on an SH needle, the first stitch being at the apex, the most dependent portion of that renal pelvis, and then running the posterior layer. One can certainly use a V-lock stitch if one desires. One can use the technique of a double-armed suture, similar to the vesico-urethral anastomosis of robotic pyeloplasty, to essentially, in the Van Velthofen running anastomosis technique. But my preference is to run that posterior aspect of the anastomosis and then essentially rotate as the stitch is seen here. You can see the instrument comes in posteriorly, rotates then to present the anterior aspect of the anastomosis, which is then closed in running fashion. Intermittently during this closure, I'll lock every third to make sure that the principles of reconstructive surgery in terms of a watertight mucosal to mucosal anastomosis and tension-free is maintained. We then dunk the stent into the renal pelvis, and intermittently I'll slide that stent to make sure that that the stent has been caught with a stitch. In the setting of stone with concomitant UPJ obstruction, one can pass a flexible nephroscope and basket that stone out of the collecting system. While my preference is to place the stent retrograde at the beginning of the case, in that setting, if one desires to place a stent antegrade, one can fill the bladder with methylene blue and allow reflux of the contrast and the dye in retrograde fashion up the stent. One can see here, once that distal portion of the stent hits the bladder, one can then know with fair confidence that the distal aspect of the stent is in good position within the bladder. In the setting of high insertion, there are many options. Foley YV plasty essentially swings that flap down from the dilated renal pelvis across the UPJ. My preference for high insertion is a Heineke-Mischkolitz fingerplasty, where essentially the UPJ, the stricture is incised in a longitudinal fashion and then closed transversely. One of the risks, if it's an intrarenal pelvis or a high insertion, is that the renal pelvis may retract into the kidney, and having that attachment helps to make sure that the renal pelvis doesn't retract. I was involved in a multi-institutional study that was reported in the Journal of Urology in 750 patients that underwent robotic pyeloplasty compared to laparoscopic pyeloplasty. In the setting of endopylotomy, 466 patients had no previous procedures, a subgroup of 54 patients. And one can see that the outcomes, generally a 94%, 95% success rate with robotic pyeloplasty, whereas in the setting of previous endopylotomy, that goes down to 89%. When one looked at the total number of secondary interventions, that success rate for robotic pyeloplasty was 97%. Looking at a multivariate analysis of factors that influence the rate of secondary procedure following robotic pyeloplasty. So secondary procedures being defined as a stent placement, endopylotomy, salvage, redo pyeloplasty. The only two factors, and a number of factors were looked at, whether or not it was a laparoscopic approach, whether or not it was not a Anderson-Hines dismembered pyeloplasty, stone, stent, etc. The only two factors that influenced the rate of having to do a second procedure was a previous endopylotomy and whether or not there was an intraoperative identification of a crossing vessel. These outcomes were also correlated in a report from the British Journal of Urology in 2018, did a meta-analysis and showed that the robotic approach was in fact 27 minutes shorter OR time compared to the laparoscopic approach, with a shorter hospital length of stay by a day, lower complication rate, and a higher success rate. And really the sentiment is that the steep learning curve, learning intracorporeal laparoscopic surgery does take some time and investment in the ergonomics for the laparoscopic approach to facilitate intracorporeal suturing. Switching gears now, just some final thoughts on work that we've been doing now for about 5 years on a buccal mucosal free graft ureteroplasty. And this is generally for patients in a very select group that has longer than 2 centimeter, on average 3 to 4 centimeter strictures of the proximal ureter. And the options in this population, are quite difficult. Ureterocalycostomy, ileoureter replacement, auto transplant. We've been looking at where essentially we harvest the buccal mucosa. One of our urologists in our department who focuses on reconstructive urology, harvests his own grafts. It's then defatted. I'm going to forward the video in the interest of time. The ureter is then isolated. Having a vessel loop to help elevate that ureter is quite helpful. And then what we do in order to help localize the stricture is that we pass a flexible ureteroscope and turn off the robotic camera light and see the transillumination of the tip of the ureteroscope. You can see actually here the tip of the needle to make sure that that's the caudal aspect of the stricture. I then put a stay stitch in order to mark that initial distal extent of the stricture. And then using the scissors, the ureteral stricture is then incised its entire length. The flexible ureteroscope is then passed all the way in the kidney to make sure that there's complete patency. The buccal mucosal graft is then introduced into the peritoneum. Using a forovicryl and an SH, the anastomosis is placed. We're going to bring a ruler in just a minute. You can see that the length of the stricture is on the order of about 3 centimeters. Using a running anastomosis, the lateral aspect of the graft is sutured down. Then place the medial aspect of the graft. My preference is to trim any redundant tissue in order to avoid any outpouching or diverticulum that may form. And so once this aspect is trimmed, the rest of the graft is sutured in place. We now have a 2-year follow-up on this particular patient, 5-year follow-up for the series. And in this particular patient that was early on in our series, we did a retrograde pyelogram at the time of his stent removal in order to ensure that the lumen was open. In fact, passed a flexible ureteroscope in order to make sure that there's good take of that graft. And one can see here that the mucosal integration has taken quite well. So in summary, robotic pyeloplasty has a 97% success rate. Our preference is an Anderson-Hines dismembered pyeloplasty in order to transpose the crossing vessel and allow good drainage. The 2 factors that really impact outcomes are whether or not the patient had undergone previous endopyelotomy and the presence of a crossing vessel. But certainly I think one new reconstructive option is buccal mucosal free graft ureteroplasty, which then gives us another option for strictures, lengthy strictures more than 2 centimeters of the proximal ureter. Thank you very much.
Thank you, Ben. Great, thank you. Excellent presentation. I have a couple of questions here, if you can help me with this. The question is, what's the role of lap pyeloplasty in the robotic era? Do you think there is still a role for the laparoscopic pyeloplasty?
Yeah, absolutely. I think that, certainly it's good to have a number of options in one's pocket. If the robot breaks down, if one doesn't have access to a robot, I think that laparoscopic pyeloplasty certainly has very high outcomes. I think the ergonomics of the robotic approach make it so easy to be able to sit down during surgery, to be able to have the depth of field, in order to be able to have a relatively quick operation. And I think that both have high outcomes. My personal preference, and I think people vote with their feet, is that my preference is robotic pyeloplasty, but I think laparoscopic intracorporeal suturing still has a valid place.
Okay, the next one is, what about the retroperitoneal approach? We are used to the transperitoneal. We have been trained in this approach, but what do you think about the retroperitoneal approach?
I think the retroperitoneal approach is a good option. It becomes harder to identify the crossing vessel because if one stays retroperitoneal, one may not identify easily the crossing vessel as much. The working space is a little bit tighter, but it's still possible. I would say that just in my practice, I would say 99% of my robotic procedures across the board, whether it's a partial nephrectomy, pyeloplasty, all robotic upper tract and laparoscopic upper tract series, I would say I'm 99% transperitoneal and perhaps only 1% retroperitoneal. And that's mainly in the setting if the patient has had an ileoconduit, a colostomy, if there is significant intra-abdominal adhesions that really make me go retroperitoneal.
Perfect. And the last one is they asking you for comments on redo pyeloplasty. What are the difficult technical aspects?
Yeah, great question. So redo pyeloplasty, and when I was in New York with Arthur Smith, Arthur really had some of the leading contributions in endopyelotomy. And in the setting of secondary UPJ, where the patient had a previous endopyelotomy, there's usually quite a significant desmoplastic response. And I'm looking forward to the talk that's coming up in terms of retroperitoneal fibrosis and ureterolysis, because some of those same principles in terms of finding the plane and then dissecting along that plane and kind of shelling out the ureter. One can do these procedures, but it usually is quite adherent. One wants to minimize the amount of cautery because certainly the vascular blood flow to that area should be maintained in order to optimize healing. Trimming any tissue that may look ischemic. There's always a balance between deciding how far to trim caudally so that you get good viable tissue, but not trim too much that the anastomosis is going to be on tension. But these are certainly possible. It's important to counsel the patient that salvage procedures of pyeloplasty following endopyelotomy are slightly lower success rates on the order of 89%.
Yes, and the last one, there's another one. They want to know about transmesocolic approach. Do you have any insights on this?
Yeah. So generally, in patients who are thinner, in the United States, obesity is pandemic. I think too many McDonald's in the United States. In the relatively thinner patients, one just can go transmesenteric, and just by seeing the transmission of light, you can see the vascular arcades through the omentum, and one essentially incises parallel to the peritoneum, and one can go mesenteric on the omentum and avoids having to reflect as much. And certainly is a valid approach, probably easier on the thinner patients, BMI in the 20s.
Okay, well, there's another one. That's the last one, I promised it. They want to know about the preparation of the buccal graft, if on the surgical table, on the side table, if there is antibiotic solution immersion, or what kind of preparation you do with the graft.
Yeah, so generally after the graft is harvested, it's just placed in isotonic saline, no antibiotics in the solution. We generally will harvest the mouth, the buccal mucosal first, because it then becomes easier to position the patient then for the, because the position of the pyeloplasty is on a modified lateral approach, it becomes easier to harvest the graft first and then position the patient for the modified lateral approach. But no special antibiotics. The mouth is closed primarily. They just do a swish and spit afterwards, similar to the same technique for urethroplasty. And in fact, we used to have the ENT surgeons harvest the buccal mucosa, but now our urologists harvest their own buccal mucosa.
Okay, Ben, thank you so much for being with us tonight. And I hope that next time you'll be here in person to give some talks here again.
It would be
Okay,
wonderful.
thank you so much, Ben. Thank you. Let's go forward. Now it's Dr. Castillo. He's going to talk about ureter replacement. Again, thank you so much, Otavio, for being here. Okay, please, if you can share your screen. Thank you.
Thank you, Oscar. Okay. I'm sharing. Okay. Okay. Well, this is the first one. Sorry. Well, you know, surgical masks are with us all day long. Coronavirus has changed our life, but it has made the opportunity to share with our friends in the distance. It's been a while time that I was in Sao Paulo, and I met Dr. Samirap. He was an example of life for me and for others and everywhere and everyone. And I have to remember my friends Licias Castillo, Anuar Mitre, Ricardo Dennis. We began with laparoscopic surgery about 25 years ago. So I remember them all my life. Well, I'm going to talk about laparoscopic and robotic ureteral replacement. Reconstructive urology right now is like a subspecialty field, and minimally invasive surgery has made a profound impact because laparoscopy has shown comparable outcome and better perioperative result compared to open surgery. And robotics overcome laparoscopic approach challenge, for example, a steep learning curve. So there is a lot of surgical technique to make ureteral replacement. Dr. Lee just talked about pyeloplasty, but there are challenging cases in patient. We have to use another resort. For upper surgery, upper ureteral surgery, we use a flank position. This is the laparoscopic flank position, and a modified flank position for the robotic surgery. We always talk about the position of the port. We use a straight line and horizontal line for do it. This is right surgery with the SI platform. You see the camera port there. And with the X platform, we use all the 8mm trocar. But you see, for renal surgery and for upper ureteral surgery, we use to put the trocars in a straight line, and it works very well, and we don't have a problem with the collision of the arms. So, as you asked recently, we published our experience in transmesocolic pyeloplasty a lot of years ago, and it's a good tool for do pyeloplasty. But there are some cases where pyeloplasty is not possible to do, maybe in redo pyeloplasty, in scouring upper ureter. So laparoscopic ureterocalicostomy or robotic ureterocalicostomy is a reliable last resource. Here is a video of a laparoscopic ureterocalicostomy done about 20 years ago or 16 years ago. This is a case I operated in Spain, and it was impossible to do a pyeloplasty because the pelvis was intrasinusal. So in this case, we dissect the renal ileum, and you see we are putting there the open surgery bulldog, because we don't have the laparoscopic bulldog at that time. We are cutting the lower pole of the kidney, and you see there is no such amount of parenchymal atrophy. So it was some kind of difficult to find the lower pole callus, but we are working on worm ischemia. So after we found the lower callus, we cut the upper ureter, we spatulated it, and then we anastomosed the ureter to the lower callus. This was a challenging case because there were no parenchymal atrophy, so it's kind of more difficult to do the ureterocalicostomy. After you finish the case, you have to do a complete hemostasis of the bleeding vessels of the parenchyma. Here we are using a 4-0 bicryl running suture. This is the lower, the first surgery of the ureter with the callus, and then we will put the WJ stent. We used to do this. We used to put the WJ stent with the by a percutaneous approach. You see, it's very easy to do that. After you put the WJ stent, you finish your anastomosis, and using, in this case, we use again 4-0 bicryl running suture. And after we finish the anastomosis, you have to do a very good hemostasis of the parenchyma, because there were no any atrophy of the parenchyma. It's just a normal parenchyma. And here you finish the case. So it was like an experimental surgery, but the robot had changed our approach, and it's quite easily to do that right now. The cases are not often to find, but here you can see the lower pole of the kidney, the parenchymal atrophy, so it's easier to find the plane of anastomosis of the ureter. You are cutting this parenchymal, and then you prepare the ureter, cutting it. This patient had a lot of surgery before, and then you spatulate it. And in this case, we use 4-0 monofilament running suture. Here we are doing the back part of the suture, and as the case before, we're gonna put the WJ stent percutaneously. So we try to not mobilize the ureter as much, because we don't want to compromise the vascularization, because otherwise there were scarring, anastomosis, and stenosis. After you finish the first part, we put the WJ stent percutaneously again, and then you finish the suture, and it's quite easily to do with the robot. You see, there is no tremor. The suture is quite quick to do that. So it looks very nice, and this patient was very well on the right. You can see the anastomosis of the ureterocalicostomy. In the middle ureter, you can use a lot of arms. You can do ureteroanastomosis. Is the stenosis is short, or as Dr. Lee showed, the oral mucosa ureteroplasty has become a nice way to solve larger stenosis. you can use the cecal appendix, just you can use it for replacement or as an only flap. And in some long ureteral problem, you can use the ilial ureter. We published a lot of time ago the laparoscopic assisted ureteral, the ilium ureter, but in that cases, you can do subtotal ilium. You anastomose the distal part to the ureter, or on the right, you can do a complete ilium ureter from the pelvis to the bladder. In these cases, because there were our first cases, we took out the ilium out of the patient, and we do it the ilium ureter extracorporeally, and the anastomosis were done intracorporeally. So right now with the robot, you can do it all intracorporeally, as we do right now the orthotopic neobladder or the ilial conduit after radical cystectomy. But we don't have experience doing ilial ureter with the robots. The cecal appendix interposition is a good option. We used to do it open in the cases when you need it, but right now you can do it with the robot easily. This is a patient where we have to replace a 12 centimeters ureter. So we took the appendix with the bladder supply. We cut the tip of the appendix to do the anastomosis to the bladder. We use this form of replacement, and we didn't do a Boari flap because this patient had a micro bladder. So we have to do anterior flap of the bladder, and then to do a submucosal tunnel to put the appendix anastomose to the bladder. This patient works this surgery pretty well, but it was we had to do a bowel augmentation of the bladder because it had a very low capacity. But you see, the appendix is a very nice way to replace a long distal compromised ureter. This is the X-ray, postoperative X-ray of this patient. The oral mucosa graft is a nice way to replace long stricture of the ureter. I will show you a case where we are doing the surgery. We didn't diagnostics before a long ureteral stricture. So with the patient in the flank position, we have to harvest mucosa, oral mucosa from the lower lip, inner lower lip. Here is the retrograde pyelogram. You see a large defect of the ureter. With the robot, we are dissecting the ureter. Sometimes it's quite difficult to identify the site of the stenosis, so you can use the flexible ureteroscope, or you can use the near infrared fluorescence with the green indocyanine dye to find out where the structure is and where the normal tissue are. There is about 5 centimeters long stricture. So here we are harvesting the lower lip inner mucosa. And we prepare it as Dr. Lee showed, and then we transfer it into the abdomen. And here we do anastomosis to the ureter using a running suture of 5/0 PDS. It's very important after you finish the surgery to wrap the ureter with fat tissue around the surgical field, or with a large epiplon prepared before do the surgery. This is a pretty nice surgery. It's easy to put the bladder, the double J stent. Here we are finishing the anastomosis with the 5/0 PDS running suture. And in this case, it was possible to do flexible ureteroscope after 5 months of the surgery. And you'll see how the mucosal graft was incorporated to the ureter very nicely. Here is the post-operative pyelogram. You see there the mucosa graft, and he is the aspect of the graft in a flexible ureteroscope. So mucosal graft is a very nice way to solve this high problem. There is some rare cases, like this patient who had a very long stenosis, and it was impossible to use the helium to replace the ureter. So we did a combination with the Boari flap and the cecal appendix interposition. Here is the video. There were a lot of scarring tissue, so it was very difficult to identify the proximal ureter. This is the right side of the patient. We excised all the tissue, the scarring tissue, and we did a long Boari flap, as you see here. You have to take care with the vascularization, so you don't have to cut the superior bladder pedicule. And after doing the Boari flap, we took the cecal appendix. So with the Boari flap, we replaced the distal ureter, and with the appendix, we replaced the proximal ureter. Here we are anastomosing the appendix to the proximal ureter. You see that there. This was quite difficult to do that, but you can do it. Proximal ureter and cecal appendix. And then you anastomose the distal appendix to the Boari flap. And this was a very nice way to replace a long ureter instead of using an ileum ureter. Here we are spatulating the ureter, and this is a way to put the wide wire. We use the 8 French feeding tube, and we introduce with this, inside this, the guide wire. You'll see that in a minute. Here is we are finished the distal anastomosis of the ureter to the Boari flap. Here we are passing through the feeding tube the guide wire, and then we are passing the double J stent. Here we finish the proximal anastomosis, and then we replace, as you see, the ureter with the long Boari flap for the distal ureter and the cecal appendix for the proximal ureter. So you see the reconstructive urologists have a lot of tools to replace ureter in a perfect form, and you can use everything you want, and the robots allows you to do this surgery pretty easily. as we do it with open surgery. Here we are finishing the surgery. We finish the body flap closing, and here you'll see the body flap distal and the appendix proximal, replacing all the ureter from the proximal ureter near the UPJ to the bladder. For the lower ureter, you can do ureteral reimplantation and body flap. The lecture will be done after this one. And one of the new surgery or technique we can do with the robot, this is doing a ureteroenteric anastomosis in a structure, principally an ileal conduit. Here, this patient had an open ileal conduit, and after 2 years, we go to with the robot to dissect the ureters and to identify them pretty well without mobilizing the ureter, so keeping the vascularization. Here we are using the indocyanine green dye with the near infrared fluorescence. Here is the left ureter. We are cutting it in the stenosis without any mobilization, and we see that the vascularization is quite nice. So after that, we are anastomosing the left and the right ureter to the ileal conduit. With the robot, it is possible to do this kind of surgery, and it's quite easily if you compare with the open surgery. And the use of indocyanine green dye help you to be sure that the ureteral irrigation is preserved. So you have seen quite a lot of different techniques that allow you to replace ureter and to solve problems like the ureteral stenosis in an ileal conduit. There is the indocyanine green dye. That is the right ureter doing the anastomosis. And after my bad Spanglish, I have to say that robotic surgery has become an invaluable tool in the reconstructive urology. The future remains strong. We continue with the adoption and innovation, and our techniques are just limited by the imagination. Thank you very much.
Thank you, Otavio. Fantastic.
Sorry because my English.
No, it's perfect. It's perfect. Thank you so much. And we can have a good idea of how skilled surgeon you are, and what a lot of very challenging cases, how you manage all this. It was amazing. Thank you so much. I have one question here is, how often you use the indocyanine green and the near infrared fluorescence during your ureteral surgeries? Because
yes.
Yeah, please go ahead.
Almost always, because you are sure that you have a right and a good irrigation of the ureter. We don't use it in partial nephrectomy. I don't see it helps it helps in that kind of surgery. But when you are doing this fine surgery in the ureter, you need the indocyanine green dye. It is helpful.
Yeah, and I just want to make a comment that there are some guys that use it intravenously. That's for to make sure that the ureter has a good arterial blood supply, and there are some that use it intraureteral. That's to have an idea of where is the stop to start making the surgery. But you can't use that then simultaneously, because if you do that, it becomes hard for you to understand what is going on. Yeah. So just it's important for those beginners that you can't use ICG intravenously and intraureteral at the same time, because you have no information for what you want. Otávio, thank you so much. It was great. It was really good to have you here. Good to see you again. I'm going to have one of your guys working with me as fellow next year, Ricardo, that I know that he's watching you. Yeah, and I hope we can see you here in Brazil again. I'm pretty sure that Januar Mitre is watching this, and thank you again. Thank you so much. Okay.
Thank you so much.
Okay, let's move on. And the next one will be Roberto. Roberto, can you share your screen, please? Thank you.
Ahí. Listo. Oscar, muchas gracias por la invitación. Vamos a ver. Bueno, un saludo a todos. Y yo les voy a hablar sobre ureterolisis. Voy a tratar de hablar despacio en español, que creo que es bastante entendible para todos los que hablan portugués. Y creo que el idioma técnico va a ayudar para que todos nos entendamos. No sé si se está viendo ahí.
Well, we don't have your screen yet. No nos tenemos la pantalla.
¿Ahí?
Sí, sí.
Perfecto. Entonces. Listo. Voy a hablar sobre ureterolisis. ¿Qué es la ureterolisis? A veces ha sido un poco mal entendida, no se tiene muy claro el concepto de lo que significa, pero básicamente es la liberación del uréter de una compresión externa por cualquier causa. Listo. Yo la había dividido técnicamente en una localización abdominal y una localización pélvica, digamos, porque las causas de la ureterolisis pueden variar de acuerdo a dónde se encuentre. Si se encuentra en el abdomen, tendríamos que pensar en una fibrosis retroperitoneal, y si se encuentra en la pelvis, por lo general, la entidad más conocida es la endometriosis, o la causa más común es la endometriosis a ese nivel. Ahora voy a solamente hacer un recuento breve de las tips importantes de la fibrosis retroperitoneal, para que, como estamos a todo nivel, tanto los expertos recuerden un poco, como los residentes también tengan estos tips muy presentes en el momento en que se enfrenten a un paciente que posiblemente requiera una ureterolisis. En cuanto al diagnóstico, se debatía qué es mejor, hacer una tomografía o hacer una resonancia magnética. En realidad, se ha visto que es igual, aporta lo mismo. Cualquiera de las dos técnicas de imagen son igualmente válidas, más va a depender de la condición del paciente. Si es un paciente que es alérgico al contraste, por ejemplo, podrá ser llevado a una resonancia magnética, pero en realidad da lo mismo cualquiera de los dos. De acuerdo a la imagen podemos tener una idea más o menos si es que es una fibrosis retroperitoneal primaria que es benigna, o una enfermedad maligna como por ejemplo un linfoma. Estas son algunas de las características importantes que voy a mostrar aquí en una imagen. Las imágenes del lado de la izquierda de la pantalla representan una malignidad. Como vemos, es una imagen nodular que desplaza los grandes vasos, desplaza también el uréter hacia lateral, mientras que las imágenes, la imagen del centro se refiere a una fibrosis retroperitoneal, como vemos una imagen mucho más nítida, como una placa. Ahora, dejé para el final lo del PET scan. El PET scan todavía no se ha demostrado que tiene una utilidad para diagnóstico de fibrosis retroperitoneal, si bien nos permite diagnosticar o diferenciar una malignidad de algo que no es maligno. Específicamente para fibrosis retroperitoneal no está todavía tipificado. Hay autores del grupo de Londres, por ejemplo, que sugiere que la fibrosis retroperitoneal puede llevarse primeramente a cirugía. Si es que el PET scan no capta demasiado, eso va a significar que va a tener una mala respuesta al tratamiento y podrían ir directamente a cirugía. Sin embargo, todavía no es un estándar utilizar PET scan para el diagnóstico. En cuanto al tratamiento, básicamente lo que los urólogos queremos saber es cuándo debemos operar a estos pacientes, ¿no es cierto? Entonces hay diferentes alternativas. En el lado izquierdo está todo el tratamiento clínico. Por lo general se empieza con un tratamiento con glucocorticoides. Si es que el paciente está muy obstruido y comprometida su función renal, debuta por lo general con una hidronefrosis. Podremos colocar un stent ureteral, un catéter J. Si es que, por ejemplo, se trata de un aneurisma que provoca una fibrosis retroperitoneal secundaria. Hay un estudio muy bueno que se publicó en el año 2017 que habla sobre la resolución de los aneurismas antes de resolver cualquier otra patología, y habitualmente el 80% de pacientes solamente con la resolución de la causa primaria, que en este caso sería el aneurisma, mejora también la fibrosis retroperitoneal y mejora la hidronefrosis. Entonces, volviendo al tema importante, ¿cuándo debemos operar? Básicamente deberíamos operar cuando no hay una respuesta adecuada al tratamiento, con glucocorticoides habitualmente 6 meses, es el tiempo más o menos de espera, y de ahí podemos plantearnos en hacer, sí, una ureterolisis, que es esta liberación del ureter de la fibrosis. Entonces, ¿qué vía elegir? ¿Qué técnica utilizar? Bueno, la técnica abierta fue la técnica descrita desde hace años atrás, ¿sí? Hasta el año 1992, en donde el grupo de Cabusi describe la técnica laparoscópica con bastante éxito en un paciente pediátrico. Más adelante pasaron 10 años hasta que el grupo de Oscar describe 13 pacientes con tratamiento exitoso de fibrosis retroperitoneal con laparoscopía, haciendo esta una técnica prácticamente de primera línea. Posteriormente a eso vienen artículos un poco más elaborados en donde comparan las vías laparoscópica y abierta, demostrando que son exactamente iguales, equivalentes, con los beneficios de la técnica mínimamente invasiva. Y por último, desde el año 2010, el grupo de Nueva York, que es el que ha trabajado también mucho en esto, ellos describen que la técnica robótica evidentemente es la técnica hoy en día de primera elección cuando se trata de tratar fibrosis retroperitoneal refractaria al tratamiento clínico. Les voy a presentar brevemente un caso y cuando vayamos viendo el video les voy a ir diciendo los trucos más importantes que debemos saber en esto. ¿Sí? Este era un paciente de 53 años, que es más o menos la edad típica de comienzo de la fibrosis retroperitoneal, hipertenso, debuta con un dolor lumbar izquierdo y en la evaluación de imagen se ve claramente ahí mostrada por las flechas una hidronefrosis y una masa retroperitoneal. Luego de que no responde al tratamiento, se coloca el catéter J y se decide hacer la cirugía. La posición del paciente es un decúbito lateral modificado a 45 grados y esta es la disposición de los trócares en forma robótica, con algo de experiencia que teníamos con el grupo del profesor Tobías. La configuración de los trócares inicialmente descrita es de esa. Se puede inclusive colocar un trócar adicional en la parte superior para traccionar mejor el uréter por parte del asistente, si es que fuera necesario. La ventaja de esta posición es que podemos tener acceso también a la vejiga y podríamos hacer una pielografía transoperatoria para identificar mejor la zona de estenosis. Este es el video que tenía para mostrar. Aquí ya hemos decolado toda la fascia de Tolt y se ve debajo el uréter. es importante aquí, parecerían bastante fácil, pero en realidad esto es una masa retroperitoneal con una fibrosis muy densa, en donde tenemos que incidir la masa de forma anterior hasta ubicar el uréter. Es una cirugía que aproximadamente toma alrededor de 2 horas y media en promedio, de acuerdo a la literatura también internacional y a lo que nosotros hemos podido evidenciar. Es importante también tomar las biopsias, como vemos que estamos haciendo ahí en este momento. Las biopsias, por lo general, son compatibles con fibrosis densa. En esta parte del video estamos fijando el colon hacia la pared lateral del abdomen, que es una de las opciones cuando no tenemos aumento o cuando el aumento es muy corto, que también ha ido bastante bien. De esa forma el uréter queda aislado del área de fibrosis retroperitoneal. Aquí voy a mostrar otro video en donde también ya se ha incidido la masa retroperitoneal, ya se ha incidido la fibrosis, estamos aislando el uréter. Con este basal loop nos ayudamos. De aquí debería el asistente tirar del basal loop para que sea más fácil la disección y el cirujano tenga las dos manos libres para poder disecar. Y la técnica es iniciar la disección de forma anterior e ir haciendo una disección circunferencial para dejar la parte posterior para el final. Por lo general, la parte más fibrótica y más adherida a los vasos ilíacos es justamente la que está sobre el vaso ilíaco, y eso es lo que dificulta y provoca la mayoría de lesiones. Entonces, esa parte se suele dejar para el final. El secreto sería empezar desde la pelvis, desde la parte cefálica del uréter, e ir bajando hasta identificar la parte fibrótica. Y asimismo, continuar hacia la parte distal hasta encontrar tejido sano, grasa sana, como ya voy a mostrar más adelante. Ese es el límite de la resección. Todo esto para no tener que utilizar todas las técnicas que el profesor Castillo nos acaba de enunciar, hacerlo con bastante cuidado, una disección Roma, tratar de evitar el uso de cauterio, tratar de evitar el uso de clips cerca del uréter, es otra de las situaciones importantes. En cuanto a la vascularización que mencionaban antes con el uso de indigocianina, en realidad, curiosamente, no se ha reportado estenosis luego de estas resecciones amplias porque se utiliza aumento, utilizamos aumento. Ya les voy a mostrar cómo se utiliza, cómo se debería hacer el flap de aumento. Básicamente recordar la irrigación del aumento, que está dada por las arterias gastroduodenales y gastroepiploicas que están penetrando por los vértices del aumento. Es decir, no deberíamos tener que cortar en los vértices del aumento para hacer nuestro flap, si no podemos cortarlo en la mitad, como vamos a ver aquí. Se puede utilizar las hot scissors o se puede utilizar armónico. ¿Sí? Se utiliza esto para cortar un poco el aumento para que el flap pueda ser adecuado como para llegar hasta el uréter. Y el borde medial lo colocamos, lo fijamos hacia la pared lateral del abdomen, debajo del uréter. Y la idea es plegar el borde del aumento sobre el uréter para que quede como un grab, como un verdadero rollo que va a mejorar la vascularidad ureteral. Es por eso que hemos evitado las estenosis. Sí. Es importante, como les decía, esto. Sin embargo, la literatura no menciona la importancia todavía del aumento, es desconocida, curiosamente. Parece que actúa como una barrera mecánica para que la fibrosis no progrese, y otros dicen que es para preservar la vascularidad. En todo caso, uno de los trucos importantes es siempre utilizar y transponer algún tejido, como ya sea el colon, como vieron en el video anterior, o ya sea el aumento, como estamos fijando en este momento con clips de hemolog o con sutura. Eso es muy importante. Y como mencioné inicialmente, realizar la disección hasta encontrar tejido sano. Eso también es vital, y dejar la parte posterior para el final. La parte posterior, que siempre es más adherida, dejarla para el final porque es la parte que más trabajo nos va a dar y que más lesiones puede provocar. Esa es una visión laparoscópica. Vemos cómo el uréter queda totalmente envuelto en aumento, y eso es lo que va a dar éxito a los casos. Aquí preparé más o menos una revisión. Esta no son datos de un metaanálisis, es una revisión propia que yo hice de la literatura que comparaba más o menos los casos de robótica y los casos de laparoscopía. y vemos que son bastante equiparables. Estos son trabajos que todavía no están hechos porque el número de casos de fibrosis retroperitoneal en realidad es muy poco. Hay pocos centros de referencia y no hay un protocolo claro establecido para tratar fibrosis retroperitoneal. Pero habitualmente todos se ponen de acuerdo más o menos en lo que les mencioné. La hospitalización habitual es alrededor de 2.6 a 3 días. Las complicaciones serias que fueron clave en 3B se produjeron en un caso en Robotic y un caso en laparoscopía, que fue una lesión entérica inadvertida por el uso de cauterio. Es por eso que se debe evitar también el uso de cauterio, ¿sí? Sin embargo, el éxito clínico en la gran mayoría de casos es muy bueno. Casi el 100% de pacientes están recuperados tras una ureterolisis siguiendo estos pasos que les había mencionado. Ahora, en la parte pélvica, solamente quería yo mencionarles un truco que publicamos realmente. Yo sé que va Rodrigo a hablar sobre reimplante ureteral a continuación, pero quería mostrarles esta opción, la opción cuando uno tiene que enfrentarse ante una fibrosis en el área pélvica y debe hacer un reimplante, sobre todo laparoscópico, que dificulta mucho y que requiere mucha más habilidad técnica. Una opción para hacer un reimplante ureteral es la técnica de Taguchi, que está descrita de forma abierta, pero que nosotros la describimos para la vía laparoscópica. Lo interesante de esto es que es solamente con un punto, es one stitch, como está publicada originalmente, y no utilizamos catéter doble J. Ha habido bastante éxito con esta técnica. Obviamente tenemos muy pocos casos todavía, pero es una alternativa para quienes hacen laparoscopía y se enfrentan a una fibrosis en el área pélvica que no puede ser resuelta, a la cual no podemos acceder y tenemos que recurrir a un reimplante. Una forma técnicamente más fácil es utilizar esta técnica de one stitch. Uno hace un punto en U en el ureter y lo fija adentro de la vejiga. Previamente se prepara la vejiga, se hace un pequeño túnel parecido al clásico Lich Gregoire y luego hacemos el cierre de la vejiga con el mismo punto, dejando un túnel submucoso que va a garantizar que sea una técnica antirreflujo. Es muchísimo más fácil y le dejo ahí en consideración de ustedes para que lo utilicen y nos comenten sus resultados, porque en realidad ha sido un excelente aporte, una buena alternativa si es que algún rato la necesitan utilizar. Eso es lo que yo quería comentarles el día de hoy, Oscar, y a todos les agradezco por la atención y para mí fue un placer estar con ustedes.
Gracias, Roberto. Excelente presentación. Roberto, ¿qué piensas del uso que la misma pregunta que ha sido para Octavio? ¿Qué piensas del uso del Indocyanine Green, Near Infrared Fluorescence, para verificar cómo está el aporte sanguíneo para el ureter? Porque en la fibrosis retroperitoneal algunas veces tiene lesiones que son son ureteres que no son muy buenos para preservar. Cuando se está haciendo la disección, se puede hacer que sean peores después, que el tejido no es tan bueno. ¿Qué piensas del uso del ICG?
Es bastante útil la indigocianina. Sin embargo, como dije, Oscar, no necesariamente nos fijamos mucho en la vascularización de este ureter, porque ya es un ureter que viene con problemas de vascularidad. Lo que hacemos es no considerar mucho la indigocianina, sino utilizar siempre el aumento que va a aportar esa vascularización que necesita el ureter y que ha sido perdida por todo el proceso de fibrosis previa. Entonces, no es una técnica indispensable utilizar en estos casos.
Gracias, Alberto. Felicitaciones. Fue una presentación muy bella, muy clara. Muchas gracias. Muchas gracias. Vamos a seguir. Let's move on. And now it's Rodrigo Quintela. Rodrigo, do you have your? Yeah. Can you share your presentation, please?
Ok. Bom, vou falar em português. Perdão aí, desculpa. Eu acabei preparando essa apresentação em português. E deixa eu compartilhar minha tela. Bom. Vocês conseguem ver aí? Tudo certo?
Sim.
Sim? Bom, então, muito obrigado aí pelo convite, Oscar, Tobias. Realmente uma honra poder participar assim, desse encontro, né, tão rico e poder trocar nesse momento, né, que a gente está reinventando as nossas vidas mesmo, essa ferramenta de poder a gente compartilhar as experiências à distância. Realmente é uma possibilidade muito boa. Eu quero compartilhar um pouco com vocês dessa minha experiência com cirurgia ureteral ao longo desses anos, desde 2002, que eu venho trabalhando com laparoscopia, recentemente agora com cirurgia robótica, apesar de não ter muitas oportunidades de realizar cirurgia robótica, né? Eu trabalho basicamente em serviços públicos, né? Aqui em Belo Horizonte, e, de uma certa maneira, estamos vivendo também essa transformação muito triste. Nós estamos vivendo esse desmonte dos serviços públicos, né, no Brasil. E, então, eu deixo aqui um pouco assim, essa minha indignação nesse momento. No entanto, a minha experiência basicamente em cirurgia laparoscópica, né, são realmente como foi compartilhado aqui. Eu acho que é uma cirurgia onde a gente tem a oportunidade exatamente de exercer talvez a verdadeira arte, né? É um dos tópicos mais desafiadores da cirurgia urológica, reconstrutora, né? A cirurgia ureteral. E, bom, essa experiência minha, ela de uma certa maneira já começou nos idos de 2003, 2004, onde eu cheguei a publicar alguns casos, né, num artigo no jornal brasileiro, Brazilian Journal. E também, exatamente, parte disso deve a essa proximidade com os hospitais que eu trabalho, que são maternidade, e também hospitais onde eu trabalho com grupos que lidam muito com litíase, né? Então, de uma certa maneira, a minha principal casuística tem a ver com as lesões cirúrgicas, principalmente ginecológicas, e lesões endoscópicas decorrentes de ureteroscopias, né? Bom, e mais recentemente também temos feito algumas cirurgias com o grupo da cirurgia pediátrica, no sentido de reimplante em casos de refluxo em crianças. Bom, algumas lições, né, que eu quero compartilhar com vocês, aprendidas ao longo desses anos. Então, realmente, como o doutor Castilho já demonstrou muito bem, é preciso da gente ter realmente um amplo arsenal de técnicas reconstrutoras para lidar com as cirurgias ureterais, porque muitas vezes a gente tem que mudar exatamente, modificar a nossa técnica, né, dependendo da situação. Eu acho que um grande avanço, realmente, o acesso minimamente invasivo, ele possibilitou uma transformação e uma melhora nesses resultados, né? Exatamente muito em relação a essa possibilidade de mobilização, né, do rim, da bexiga, né, de fazer uma dissecção em toda a extensão do ureter. Isso possibilita exatamente reduzir a tensão anastomótica, que é talvez o ponto principal em relação ao resultado. E a gente realmente consegue, através de um acesso, ter toda essa mobilização, e acho que esse é um grande diferencial da cirurgia minimamente invasiva. Um outro ponto que a gente observou é que existe, muitas vezes, uma tendência a você ressecar mais do que o necessário da área fibrótica, exatamente por, muitas vezes, não ter exatamente essa precisão da extensão. Muitas vezes é difícil a gente ter a precisão da extensão da área, né? E muitas vezes você tem um ureter dilatado a montante e é difícil precisar exatamente a necessidade, a área de ressecção. Então, é preciso ter esse cuidado na ressecção de uma área fibrótica. A questão da anastomose sem tensão é fundamental e o escape de urina é um dos fatores principais que aumenta o grau de fibrose. Eu tenho uma experiência que também vem um pouco dessa experiência inicial com cirurgia de cálculo por laparoscopia, né? No início da experiência, a gente não tinha muitos recursos endoscópicos, então lançava muito mão de laparoscopia em cirurgias de cálculo renal e ureteral. E, inicialmente, a minha experiência foi muito pelo acesso retroperitoneal. No entanto, eu vejo que, né, rapidamente a gente mudou, porque o acesso retroperitoneal na cirurgia de ureter, você tem mais a possibilidade de provocar uma fibrose retroperitoneal, né? Como mostrou muito bem o Roberto na sua apresentação. Esse é talvez um diferencial, uma das perguntas também do Dr. Lee no início da apresentação, exatamente desse acesso retroperitoneal. Eu acho que o acesso retroperitoneal para a cirurgia ureteral ele é inferior ao acesso transperitoneal, exatamente porque provoca mais essa fibrose, né? E acho que uma das principais lições aprendidas é exatamente a peritonização ou a realização da aumentoplastia no revestimento do ureter, que vai melhorar a mobilidade, diminuir essa fibrose retroperitoneal. Também penso que é sempre preferível anastomosar ou na bexiga diretamente ou na pelve e evitar, sempre que possível, anastomoses terminais, né? Muitas vezes, vamos dizer, claro que no ureter médio, muitas vezes é a anastomose térmico-terminal a primeira escolha, mas se você tem uma lesão pélvica ou mais proximal, se possível, já fazer uma anastomose numa área mais dilatada. Eu também sempre tenho essa observação de não, muitas vezes, se possível, não drenar a via urinária perioperatória, ou com duplo J, ou com nefrostomia, exatamente porque a dilatação ela favorece, muitas vezes, a reconstrução. Então, essa também é uma lição aprendida, sempre que possível, não realizar a drenagem do paciente. E uma outra experiência muito interessante que eu gostaria de compartilhar é exatamente a questão da intervenção precoce, porque realmente talvez aquela máxima da cirurgia aberta, onde a gente esperava, né, essa estenose se consolidar, né, ela tem mudado exatamente depois da era da cirurgia minimamente invasiva. E a minha experiência mostra, assim, alguns casos de sucesso, desde que possível, desde que a condição clínica do paciente permita a intervenção precoce. Então, eu acho que essa é uma possibilidade que a gente tem que considerar, né, na reconstrução, porque muitas vezes você evita exatamente a realização de técnicas mais complexas. E sempre também considerar, principalmente, né, para o paciente, que a possibilidade da nefrectomia, muitas vezes, em casos muito complexos, é talvez a melhor escolha. Em relação aos exames, né, a questão exatamente, o desafio é exatamente a gente saber a extensão exata dessa altura e a extensão exata da área de fibrose. Eu, na minha posicionamento perioperatório, né, em relação à cirurgia de reimplante, a gente sempre realiza o mesmo acesso para cirurgias pélvicas, né? De uma certa maneira, é o acesso que eu utilizo também nos casos de prostatectomia, utilizando um trocate da mão direita bem suprapúbico. E a gente tem sempre essa possibilidade de permitir um acesso também endoscópico, tanto perioperatório, tanto pela via vesical ou pelos próprios portais da laparoscópicos. Bom, então, a gente sempre pensar em relação à disposição dos portais, que eventualmente vai ter que fazer a mobilização renal, a mobilização vesical, né? Sempre iniciar a dissecção do ureter fora da área mais comprometida, né? a mobilização, no caso do reimplante, a mobilização vesical, muitas vezes, só a mobilização bilateral já possibilita evitar uma técnica mais complexa de Boari ou bexiga psoica, né? E sempre a realização da anastomose contínua, né? Eu realizo essa anastomose de uma certa maneira, tendo o mesmo princípio da anastomose contínua, no caso da prostatectomia, da anastomose vésico-uretral, né? Então, no caso, a gente realiza mais ou menos esse mesmo princípio técnico. Acho que já foi colocado aí, né, em relação à literatura, aí, a grande novidade talvez seja o flap de mucosa bucal, que eu acho que talvez venha trazer exatamente um novo universo para a cirurgia reconstrutora ureteral. Eu não tenho experiência, mas achei muito interessante as experiências compartilhadas aí do Dr. Li, do Dr. Castilho, e realmente essa questão da mobilização renal, muitas vezes, hoje, cada vez mais, ela é celebrada como uma alternativa para reduzir exatamente a tensão e, muitas vezes, técnicas mais complexas. Esse é um caso que eu compartilho aí com vocês, um caso, de uma certa maneira, mais... um caso mais simples de estenose pós-ureteroscopia, né? Uma estenose já próxima a uma estenose do ureter pélvico, né? Então, é mais ou menos a técnica que nós utilizamos, uma técnica básica, né? Onde a gente faz essa repressão vesical com soro fisiológico para identificar melhor a área de reimplante, né? Fazemos aí uma dissecção que vai permitir o reimplante depois criar um túnel, né? No sentido de evitar diminuir o refluxo, né? E fazemos aí esse reimplante. Eu sempre utilizo esse artifício de utilizar a cânula do aspirador para colocação do duplo J, né? O que facilita, evita outras funções, e a gente faz essa sutura, na verdade, como eu havia falado, utilizando um pouco essa ideia da anastomose, né? No caso da prostatectomia radical. Então, a gente começa a anastomose mais ou menos em torno de 5 horas, né? E fazemos uma sutura contínua, imaginando que, no caso aí, o ureter corresponde à bexiga, né? E a bexiga ali, no caso, corresponde à uretra. Então, bom, não tem maiores segredos aí, a realização dessa anastomose. Bom, esse é um caso que exatamente a gente mostra exatamente uma paciente que foi submetida a uma esterectomia abdominal e apresentou uma fístula, né, um urinoma com um escape de urina, exatamente logo essa é uma cirurgia realizada no 5º DPO, no 5º dia de pós-operatório, exatamente para mostrar a possibilidade, né, uma paciente que estava clinicamente bem, que nos permitiu realizar essa cirurgia precocemente e não aguardar exatamente o tempo que, de uma certa maneira, se aguarda. Isso evita, talvez, né, acho que hoje a gente exatamente vê essa possibilidade com a cirurgia minimamente invasiva. Então, vocês estão vendo já uma dissecção, a área onde foi realizado o ponto, né? Esse foi o local, uma sutura que envolveu a região ureteral, né? A gente faz a dissecção do ureter fora da área mais comprometida, e isso, né, possibilita a gente identificar melhor a lesão, né, o ureter. Vocês estão vendo, de uma certa maneira, esse foi um caso onde não houve nesse momento, né, houve uma lesão parcial do ureter, não era uma lesão total, ele foi envolvido, que de uma certa maneira é o mais comum que acontece nas cirurgias ginecológicas, ureter ser envolvido por algum ponto próximo, né, em ligaduras vasculares das artérias, as artérias uterinas, né? Então, aí a gente vê um pouco aí já essa... Vamos correr um pouquinho mais aqui o nosso... E a gente consegue perceber, né, uma lesão parcial do ureter, a área de lesão, né? Então, foi possível a gente realizar a paciente já estava posicionada para a realização de uma ureteroscopia, onde a gente colocou, né, um guia, um fio guia, através do ureter, recuperando ele na cavidade abdominal. Vamos seguir aqui um pouquinho. Então, vocês estão vendo aí o guia recuperado pela lesão. Então, foi realizado, na verdade, uma cateterização desse ureter e a partir daí a gente conseguiu resolver o caso, né, apenas com uma rafia dessa área de lesão, um cateterismo e uma ureterólise, onde possibilitou abreviar tanto o tempo de espera para uma cirurgia reconstrutora, quanto realmente a realização de uma técnica mais complexa. Bom, esse é um outro caso, né, que a gente às vezes lança a mão, uma cirurgia, uma lesão ureteral também pós-esterectomia, pós-cirurgia. Esse caso não foi esterectomia, não, foi uma cirurgia ginecológica de endometriose e uma lesão ureteral mais proximal. E a gente, muitas vezes, lança a mão do recurso de utilizar a técnica de Boari, né, que vai ser mostrada aí, mas eu compartilho um pouco com vocês esse caso que demonstra um pouco a viabilidade da realização dessa técnica. Muitas vezes a gente não cria mesmo, a minha técnica, eu não crio muito o flap, muitas vezes só de fazer a abertura transversal da parede vesical, é possível você, né, tracionando a bexiga, já criando o psoas rite, ela já cria essa deformação em triangular e permite a gente fazer a anastomose, né, sem tensão. Quero compartilhar também um pouco essa técnica que, né, nós temos realizado em casos de reimplante para refluxo. Essa é uma criança de 2 anos. Essa é uma cirurgia totalmente intravesical, né, que a gente coloca os portais direto na bexiga, né? É possível, já fizemos em crianças até de 1 ano, né? Habitualmente são pacientes operados um pouco maiores, crianças de 5 anos, mas é possível a gente realizar mesmo em bexigas pequenas. Então, a gente cria um túnel, né? É a cirurgia de Cohen que a gente faz, é possível fazer totalmente intravesical, e a gente faz essa mobilização do ureter para dentro da bexiga, criamos o túnel submucoso e fazemos essa anastomose, né, exatamente criando uma válvula antirrefluxo, o que é uma cirurgia que nós temos, inclusive, já alguns casos, talvez aí uns 30 casos, que está em vias de publicação, mas eu acho que é uma das possibilidades bem interessantes da cirurgia minimamente invasiva. Esse é um caso recente que nós fizemos exatamente uma reconstrução com o tubo de monte, que, no meu ver, ele é preferencial, é superior exatamente à interposição completa de ilha. Essa é a parte externa da cirurgia, onde a gente faz exatamente através desse pequeno segmento de 5 centímetros de alça intestinal, nós fazemos uma 2 tubos que vai permitir quase que a interposição de um ureter inteiro. Era um paciente que houve uma avulsão do ureter proximal por uma cirurgia, uma ureteroscopia para tratamento de cálculo, e foi feita essa reconstrução com implante. Ele, na verdade, na verdade, é a anastomose ureteral proximal, né? Esse é um vídeo também de baixa qualidade, porque foi filmado com uma câmera de celular aí da tela da cirurgia. Infelizmente, nós não tivemos como gravar a cirurgia, mas é a possibilidade de realizar essa técnica onde a gente confecciona uma alça intestinal detubulizada e ela tem exatamente uma possibilidade de ficar mais simétrica em relação ao calibre ureteral. Não é o caso da aula do reimplante, é apenas uma... Esse é também um caso para demonstrar exatamente essa história de intervenção na fase aguda. Esse é um vídeo exatamente de um residente que, no momento de uma cirurgia de ureteroscopia, houve a avulsão do ureter e foi exatamente entrado de maneira já imediata, foi posicionado o paciente para a cirurgia laparoscópica e foi realizado o reimplante no momento da secção do ureter. O paciente que teve uma boa evolução, está com as vias urinárias reconstruídas e pérvias. Então, é só para demonstrar a viabilidade desse acesso. Realmente, cada vez mais, a gente divulga essa possibilidade da realização da cirurgia reconstrutora na fase aguda, exatamente porque ela tem um impacto, uma morbidade menor. Bom, esse é um caso também de um reimplante em casos de ureter dilatados, onde muitas vezes, de uma certa maneira, é uma cirurgia que não tem maiores dificuldades, um paciente com mega ureter congênito. A gente não é uma cirurgia, vamos dizer, que a gente preocupa, nesse caso, muito com a questão do refluxo, porque o paciente já tem realmente um calibre ureteral, um ureter muito calibroso, mas habitualmente é uma cirurgia relativamente tranquila, simples. Bom, acho que em virtude do tempo, eu encerro a minha apresentação aqui agradecendo e uma ótima oportunidade da gente poder compartilhar essas experiências aí à distância. Muito obrigado.
Obrigado, viu, Quintela? Foi excelente. A sua experiência, a gente percebe que é muito grande e realmente eu acho que o importante de um webinar como este é mostrar muitas alternativas, muitas opções e ter conhecimento dessas técnicas, alguns truques e dicas que foram passadas pelos palestrantes. Acho que isso é muito importante. Deixa eu perguntar uma coisa só para você que fez muitos casos de refluxo. Tem uma pergunta, deixa eu ver aqui, que ele pediu para comentar em relação a algumas as anastomoses refluxivas e não refluxivas, Como você mostrou alguns casos, você não faz questão, como no mega ureter congênito, de uma anastomose antirrefluxiva. E, em alguns casos, é lógico, sempre que possível, nós tentamos fazer uma válvula antirrefluxo. Naqueles pacientes que você não fez uma anastomose com uma válvula, você teve muitas complicações nesses pacientes?
Então, eu percebo que, na verdade, a questão do refluxo, ela é secundária. Muitas vezes a gente faz a cirurgia exatamente em casos de estenose, exatamente, já é um ganho para o paciente a gente conseguir fazer o reimplante. Então, a questão do refluxo, para mim, ela é uma questão secundária. Esse caso, por exemplo, de um mega ureter congênito, a impressão que eu tenho é que exatamente o calibre do ureter, é muito difícil esse paciente ter alguma repercussão renal, né? Exatamente por esse calibre ureteral. Então, ele tem, vamos dizer assim, uma elasticidade, né, que dificilmente ele vai ter uma repercussão por pressão. E são pacientes que também, vamos dizer assim, a gente sempre orienta essa questão da urina em 2 tempos para diminuir o resíduo vesical e, de uma certa maneira, não é uma questão frequente nesses pacientes, talvez até pela própria questão da patologia, a questão da infecção de repetição. Mas, em alguns casos, realmente, em pacientes onde a gente, né, não teve condição de fazer a válvula antirrefluxo, eu sempre faço quando possível, né? Mas acho que, em alguns casos, onde essa questão da realização da válvula antirrefluxo não é possível, eu já vivi alguns casos onde o paciente realmente teve comprometimento no sentido assim, de infecção de repetição e também de pressão na via urinária, onde nós utilizamos essa mesma cirurgia. Infelizmente, eu não tenho as imagens, mas essa cirurgia que a gente faz em criança, né, na cirurgia intravesical para a realização do refluxo, para a correção do refluxo, é uma opção nos casos de reimplante ureteral, onde você, posteriormente, vê a necessidade de realizar um refluxo. Então, eu já tive a oportunidade de fazer em 2 pacientes, né? Infelizmente, eu não tenho essas imagens, mas são cirurgias que não são cirurgias complicadas tecnicamente. Você entra intravesical, faz a ressecção ali do neomeato ureteral e traz o máximo de ureter para dentro da bexiga e cria um túnel ureteral, né? E é possível você fazer essa cirurgia de Cohen para a reconstrução de unidades que são refluxivas em reimplantes ureterais. Então, é também uma possibilidade.
Excelente. Rodrigo, foi muito interessante essa técnica intravesical. Eu tinha mais algumas perguntas, mas, infelizmente, por causa do horário, eu vou dar prosseguimento. Obrigado, viu, Quintela?
Obrigado.
Vamos agora... let's move on to Marco Aurelio. He is going to talk about body flap and psoas hitch. Marco, can you share your screen, please?
Mentira. Vou colocar isso aqui. Hold on a second. Tem que colocar assim aqui. Qual que era mesmo? Magda, qual que é a senha? 07. 1981. 63. Não, 63. 0763. Ok, deu certo. Can you hear me?
Yeah.
Okay. Good evening, everyone. First of all, I'd like to thank Brazil and all the organizers of this tremendous webinar. I would like to also congratulate all the panelists for the brilliant presentations. Especially, I would like to thank Oscar for the kind invitation. I'm very honored to be here. Thank you so much. I was asked to talk about the Boari flaps and psoas hitch. Boari flap was originally described in 1894 in a canine model. Although Boari, for me, sounded like an African name, he was actually a professor of surgery and anatomy in Ferrara, Italy. Achille Boari dedicated most of his life studying ways of replacing injured ureters. But it was only 42 years after his original publication in 1936 that 2 Yale surgeons, Åkerblatt and Carlson, applied his technique in a human patient for the first time. Nowadays, the Boari flap is universally recognized as an effective technique to replace damaged inferior ureters. Oscar Fujita and Kavusi, our Oscar here, our moderator here, were the first to successfully perform it laparoscopically in 2001. Since then, many have reproduced this technique with excellent results. This first experience was actually an inspiration which has motivated many of us to do it. The first robotic assisted Boari flap was performed in 2008 by Schems and Wagner at Michigan University. Here in Londrina, we have been doing laparoscopic Boari flaps for quite some time now. However, we have the Da Vinci system for just over a year now, and we haven't had the opportunity to do a Boari robotically yet. So the main indications for Boari flaps are lower and extensive ureteral defects, usually a consequence of pelvic surgeries like gynecological procedures, endoscopic urologic surgeries like rigid or flexible URS, traumas, and more recently, also distal cases of transitional cell carcinomas. Indications for psoas hitch is any situation you feel there would be some tension in the vasculoureteral anastomosis. Boari flaps can be done in two manners, either with a reflux or a non-refluxing reimplantation. Both techniques are effective and neither appear to affect renal function. Non-refluxing reimplantation need a submucosal tunnel, as Oscar just said, and are more challenging. Because of that, it offers higher risk of stenosis. One thing you should consider is, if the future access to the ureter is important, a refluxing technique should be your choice. The case I'm presenting here today is a 21-year-old female patient who came to our hospital with pain in the left flank, and she had a high temperature for 3 days. She had pyuria, high white blood count, and high reactive C protein. She had a history of passing stones in the left kidney, no previous operation, and she had no other comorbidities. A CT scan showed a 1.6 calculus in the left distal ureter and a dilation of the upper urinary tract, this configuring an obstructive pyelonephritis. The first thing we did was trying to pass a stent from below, but we were not successful. So we did a kidney ultrasound guided puncture and a nephrostomy tube was secured. After 2 weeks of antibiotics and resolution of the infection, we did a retrograde pyelography, which I will show you in a minute. And that at this time, we managed to pass the catheter through the nephrostomy down to the bladder. So here's the pyelography showing a stricture of the lower ureter. Considering then the extensive stricture of the left distal ureter, her history of passing calculi, and the future need to access this ureter, our option was a laparoscopic Boari flap. So hold on a second. The positioning of the patient for Boari flaps obeys the same rules we use for all ureteral reimplantations. The patient is placed in the supine Trendelenburg position to move the bowels from the bladder. I don't see any need for lithotomy position unless you are doing it robotically. We use a transperitoneal approach, and trocars are placed in the same fashion as we do for radical cystectomies, with the camera port just above the umbilicus. So I'm showing the movie of this, or the video of this operation now. We start by doing a Maytux maneuver. In other words, mobilizing the column medially to facilitate identifying the ureter. When you're looking for the ureter, you should look for the traditional anatomical landmarks, such as the gonadal veins and the iliac vessels, as I will show you in a minute. So this is the gonadal, the left gonadal veins in this case are very well shown, and here as well, the ureter on your right. To help with your dissection, you can place a vessel loop to hold the ureter, which will facilitate your dissection. The care should be taken to preserve the irrigation of the ureter. So try not dissecting too close to the ureteral wall. So we proceed with the dissection. The ureter is carefully dissected towards the fibrotic area, which is over there. Once the dissection is completed, the ureter will be transected just above the fibrosis. In this case, usually we use a cold scissors to transect the ureter, as you're going to see right now. As there was a stone in this case, we have dissected a little bit further down just to take out the calculus. Okay. Once you've completed the dissection, the ureter is you're going to do the spatulation of the ureter. We do a 0.5 centimeter ventral cut in the dilated lumen of the ureter. If you have any difficulty in doing a spatulation, you can place a plastic urethral catheter to facilitate your cutting, like this. Then you proceed with your incision. That's a nice spatulation. Once you finish that, you can get rid of all this periureteral tissue because this will facilitate your anastomosis. You see a nice ureter over here. Well, next step is to drop the bladder from the abdominal wall. We all are familiar with this anatomy. We incise the urachus, then we cut the peritoneum, both on the right-hand side and then the left-hand side. And from here, the dissection is mostly a blunt dissection. We avoid dissecting, of course, below the area where the bladder pedicle is. It is desirable, if you're doing laparoscopy, as in this case, to use either a bipolar Maryland forceps like ligature, or an ultrasonic forceps which seals and cut in sequence. This type of forceps actually save a lot of surgical time. So here the bladder is dissected. We are looking for the rectal space. So nearly done. A little more dissection here. We are very familiar with this space. Everybody who does prostatectomies and cystectomies, they are familiar with this anatomy. A little bit more of this dissection. Now you have the rectal space fully developed here, and the pubic bone and the bladder over here. Okay. Once you finish dissecting the bladder, Then you start marking the limits of the future flap. It's easier to use a laparoscopic hook to do it. Of most importance is to have a flap with a nice broad base, because the irrigation of the flap comes from its base. So it's really important to have a very nice flap with a broad base, as I'm showing here. If you would require a longer flap, you may define a curve or a spiral shape in the bladder, or even consider a bladder zetaplasty. We prefer to cut the bladder with no energy as well to prevent burning of the detrusor, which could compromise the integrity of the flap. Complications specific to the Bovary flaps include ischemia of the flap, reduced lumen size of the flap secondary to thickened bladder wall and reflux. Because the blood supply of the Bovary flap comes from its base, any devascularization of the bladder base may cause ischemia and eventual necrosis. Now you pull the ureter towards the flap and comes nicely without tension, as you can see. At this point, you will have to decide if you're going to do a psoas or want. Some surgeons always do it with the argument of stabilizing the future tube. Myself, I do it when I see that there would be some tension in the ureteral bladder anastomosis. Of course, it's crucial to have a tension-free anastomosis in all cases. The video, which I'm going to show you now, are courtesy images from Dr. Stiefelman, who is doing a psoas robotically assisted. The psoas is nicely dissected. The genital femoral nerve is identified. And here the iliac vessels are on your left. You can actually see the pulse of those vessels. One thing very important is that your stitches should be done longitudinal to the muscle fibers, not transversal. So avoid transversal stitches. And 2 stitches are sufficient for the psoas. If you're doing laparoscopically, you should do exactly the same as I'm showing in this video here. Perhaps your assistant will have to hold the bladder for you. Now he's passing the needle in the muscle, he's pulling the bladder towards the psoas and comes nicely. And now he's going to pass the needle through the detrusor without entering the bladder, as you can appreciate now. Of course, the robot will facilitate your stitches very much, but the procedure is absolutely the same, either here or laparoscopically. I'll move forward a little bit. Now he's making sure his bladder has not been entered. So coming back to our operation, next step is to do the anastomosis of the ureter to the bladder flap. We use 2 sutures. These first stitches are done between the bladder flap and the vertex of the spatulated ureter. These first stitches are important because they do stabilize the anastomosis, as you can see here. Once you've done these stitches, you can start either posteriorly by the medial or the lateral aspect of the anastomosis. We are doing here first the lateral aspect of the anastomosis. Some surgeons, they do prefer interrupted stitches, but we routinely use running sutures with very good results. Actually, we never had a case of stenosis. In some cases, again, if you are having trouble to see the ureteral wall, you can place a plastic catheter or anything similar, as we did before, just to facilitate suturing and prevent future stenosis. Because there is always a disproportion between the thickness of the bladder wall and the bladder and the wall of the ureter, as you can see here. I'll move forward a little bit. After completing the first part of the anastomosis, a catheter is placed either through a puncture, or if it's a male patient, you can use the Foley catheter to pass a guide wire and facilitate passing the stent. From now, we are completing the anastomosis. And I'll move forward a little bit. So, finishing the anastomosis, which is okay. And now we are going to close the bladder and the Boari tube. We have used, in this case, a 4-hole Vicro, but I have used also PDS in the past, and in some cases, barbed sutures as well. If you ask me which one I would prefer, I think I would say barbed suture. Both, I have used both V-Lock or Stratafix, and I think they're fine because it's easier to do this anastomosis with this sort of sutures. Okay. Just completing the closure of the Boari tube and also the bladder. Yeah, so okay. So the bladder is closed, the anastomosis is completed. This is the final aspect, and it's done. So there was no major issue during the operation. It just took under 3 hours, and there was no significant bleeding. Patient was discharged after 3 days, and a Foley catheter was kept for 14 days and taken out after a cystography. The stent was retrieved after 4 weeks, and the patient was okay, and he didn't need any readmissions after the procedure. Here is intravenous pyelogram showing a normal drainage of the left unit and a nice capacity of the bladder. This last part of the video is the cystoscopy in the day when we took the catheter out. So here we can appreciate the Boari tube from inside the bladder, and we can see how easy it is to access this ureter if it's necessary. So Boari flap is a great technique and must be strongly considered in cases of lower ureteral stenosis. Some take-home messages. Boari flap is and with or without psoas is a very elegant operation. Always do a very careful dissection of the ureter. The flap should always have a very large base. Make sure you have a tension-free anastomosis do a psoas hitch if it's necessary, and considering a refluxing technique if the access to the ureter is important. I would like to thank Dr. William Nito, who helped with this presentation and the editing of this film. Thank you very much, William. And I would like to thank my residents at the university, Dr. Garbin and Kasuya, and just to say thank you for the enthusiasm and the dedication, and I'm very proud of you. Thank you.
Excellent, Marco. Thank you so much. A very nice video, very clear, and there are some very nice tips and tricks. You pointed out the important things that we have to take care about. And just one question of the audience. They want to know how do you know the gap limits to indicate the body flap and the psoas hitch or iliac interposition or something else? How do you work with this? Is there any gap limit that you use to indicate the Boari and the psoas?
Well, I think there isn't a magical number. However, if I consider that I have to enter this ureter again, I would consider a Boari flap. But if it's a lesion more than 3 centimeters, I think I would do a psoas hitch as well. Or do a Boari flap as well.
Okay, great. If I can see all the other speakers, and yes, because I want to ask Tobias, that he is the guy that is in charge of all these scientific programs, of all these webinars. Please, Tobias, go ahead. Feel free.
Bom, eu queria agradecer a todos, né? Thank you very much for all. Brilliant and fantastic presentations, nice cases, nice difficult cases. Né? Agradecer pessoalmente a todos, né? E fazer o anúncio para a nossa reunião da próxima semana, que é uma reunião dedicada à endometriose. A gente vai ter um dos maiores especialistas, que é um ginecologista, dando uma aula sobre endometriose, depois um painel com 4 urologistas mostrando casos também, bexiga, ureter, envolvendo a doença da endometriose. Então, mais uma vez, agradecer a todos. E é isso aí. Se você quiser terminar, concluir, Fujita, parabéns para você, porque a reunião foi espetacular. Parabéns mesmo, muito grato.
Thank you, Tobias. Well, thank you all, Ben, Otávio, Roberto, Rodrigo, and Marco. It was great to have you all here. Great friends I have, and it was a fantastic meeting. And I hope that we have the opportunity to have you all here in São Paulo, Brazil, at some time, so that we can share all this experience in person and have you to have some churrascos and beers here in Brazil. Yes. Okay. Thank you so much. Thank you for the audience that stayed so long here, but the presentations were so brilliant that I think it was worth it. Thank you so much, and see you next week.